And thank you all for coming here as your plenary today. So as Tim said, my name is Hannah, and I'm a clinical fellow with Pathway and have been doing this large piece of work which I want to share with you today. It's effectively a service evaluation of looking at some of the Pathway teams. And so I want to just go through what our objectives were, what our methodology used was, and then what our findings were. And then hopefully that might create a bit of a discussion. So I think you'll know most of this already. We've heard it throughout the conference, but inclusion health is such a big issue that is close to probably all our hearts just by being here. And it does include those, not just rough sleeping, but the hidden homeless and those in temporary accommodation. And it's a big problem, it's getting worse. I also wanted to touch on the morbidity of homelessness, because this is a particular thing we tried to look at within our evaluation. And this, again, you're probably all very well aware of, is the complex overlap of the physical health needs of someone with their mental illness problems and substance misuse. So what were the issues, and why did we even set out to do this piece of work? There's a real challenge with collecting data within this population. It's something we, again, heard yesterday. We need a lot of data to be able to secure funding. We need to show that our services are making big difference, big impacts, they're saving the NHS money, so we should be funded. And we seem to constantly be needing to fight that argument. And it's an argument that the initiating Pathway team seems to show quite clearly, that when you bring in a service, when you work closely with these people, you are then saving the NHS money by reducing readmissions, etc. It's really difficult to get common data within this population. There's lots of challenges, and it's really hard to do the usual data collection searches that are done within NHS, because people, we've heard again in the previous section, people might use a friend's address, they might not be disclosing their homelessness, it depends whether they're put as NFA or no fixed abode. So what I was giving some time to Pathway, and what we decided would be really useful is to look at patients we know are homelessness and admitted to hospital, and spend a lot of time going through each of their inpatient admissions. So this was our objective. We wanted to explore the reasons that patients that were referred to a Pathway hospital homeless team were being hospitalised, and particularly we wanted to look at their secondary care usage 120 days, so 3 months before that admission, and then 3 months following their day of discharge. And I think in the back of our mind, we were thinking, well, we've got these great studies shown when you set up a service that we see a great change in their numbers. We see fewer A&E admission attendances, fewer hospital admissions. So this is what we want to show across our teams. So what did we do? So first of all, there are 10 Pathway teams across the country, and I was able to visit 7 of these teams to look at their data. The teams are listed here. It might not project very well, but the highlighted ones: Bradford, Brighton, Guy's and St Thomas's, King's, Manchester, the Royal London, and UCLH were the teams that I attended. South London and Maudsley focuses on mental health. They've got a lot of other studies going, so they were excluded. Leeds were having a team restructuring, and Bristol was a very new service at the time, because this piece of work happened in 2016. So our methodology, across these 7 teams, we looked at 6 months worth of data. It would have been ideal to look at a year, but it was quite a laborious process, shall we say. So from the 1st of January to the 30th of June 2016, every patient that was admitted to those 7 hospital teams were looked at. So it was a retrospective analysis. We captured the demographic details that were available, looked at their reason for admission, mainly taken from discharge summaries, and then we looked at the usage, how many times they'd been into A&E, how many times they were admitted. The A&E attendances, that's when they attended A&E but weren't admitted. Unplanned admissions was coming in through A&E and getting admitted. And then planned admissions, so that's coming in, say, to the medical day unit for a planned transfusion or a planned procedure or an operation. And then we were able to look at why these people were admitted, and we classified these using the International Classification of Diseases to look at the types of things people were presenting with. So we excluded anyone that was referred to the Pathway team but only seen in A&E. We only looked at inpatients, so people that were admitted. So that also excluded those that were seen in the community. and any referrals, people that have been referred but not properly assessed by the pathway team as being homeless were excluded as well, because it was such an in-depth analysis to try and really capture those people that were experiencing homelessness. So this is just a bit of a disclaimer about how we captured our data handling. You could probably read that yourselves, but the big thing to note is that we did include frequent attenders. We felt it was appropriate to capture the nature of this population, so the frequent attenders were included and we weren't excluded. And as you can imagine, with some of the difficulties of data collection, missing data was just kept as a separate category for percentages because there were cases where a lot was missing. So what did we find? A lot of our demographics were consistent with the literature. We had 1,663 referrals to the Pathway homeless team over that 6-month period. And about a third of those were excluded because they weren't hospital admissions with people that had been assessed as experiencing homelessness. Of those 1,135 inpatient stay, 1,009 of them were patients. So that meant, I think it was 91 patients accounted for 217 admissions, so an average of 2.5 per admission. Again, we didn't exclude frequent attenders. The average age on admission was 43, and there was just a note that this is probably underrepresented, but 6.5% were documented as having no recourse to public funds on the pathway notes. We saw 3/4 of our population were male, consistent with the literature again, and we were, that doesn't project very well, but our housing status, so the big blob, we categorised it into 4 bands. The first band was rough sleeping or no fixed abode. The second band is the red at the bottom, was unsuitable housing or safer surfing, staying with a friend. The sort of light greeny colour is hostel or temporary accommodation, and then medical care or council funding, which was particularly evident somewhere like Bradford, where they've got their bricks, their hospital step-down facility. And then the top is unknown or missing data. So about 45% were no fixed abode or rough sleeping. So this is the spread of data for the ICD-10 categories. And what we saw here was actually the majority of patients. The pink is, we classified people as a primary diagnosis, and then we also looked at a secondary diagnosis because of the complexities of the reasons people were presenting. And we actually saw quite starkly that most patients were presenting with some form of mental and behavioural disorders, things like coming in with an overdose, suicidal ideations, alcohol intoxication, or withdrawal. And we then saw our next most common was actually a category called external causes of morbidity and mortality, followed by injury and poisoning. There's a lot of overlap within these categories. The way that ICD-10 separates them out is that 20, the external causes, morbidity or mortality, is basically something that's happened to someone, whether they've had a hit by a car or they've been assaulted or stabbed. And injury and poisoning is then the consequences of those things, so whether they've experienced a fracture or brain injury or cut or wound. This is quite interesting coming out of the data. I was looking at the spread of the physical health, mental illness, and substance misuse. And what's quite startling is 95% of those admissions actually had a physical health need, whether it was their primary presenting complaint or their secondary, which actually shows that a lot of these patients are in a place where they need hospital care. That's either in isolation physically, which is about 40%, or with a concurrent substance misuse issue, mental illness issue, or presenting with the others on their own. It's also important to note that about 3% we didn't have this data for. It's very variable about how the data is coded as well. This, again, hasn't projected very well, but from the pathway data, we were just trying to break down within those with substance misuse issues, whether that was primarily due to drugs or alcohol. But I think the main point to say from this is a real underrepresentation of what people feel they're seeing out on the shop floor. And again, it really goes down to how things are coded and documented and how that's so varied around sites. Can everyone see that table? It might be a bit small. This was the shocking part of our research, I think. We were really hoping to look at the A&E attendances and the admissions and how those changed, I've already alluded to. The top half was the number of secondary care attendances before the patient was assessed and seen by the homeless pathway team. And then the bottom part of the table is afterwards. And although we did see a small but not statistically significant fall in A&E attendances, we did see a rise in planned admissions, which was statistically significant, but also a small rise in unplanned admissions, which I'll expand on in a moment. The average length of stay for the admissions where the patients were seen and assessed by the pathway team was 14 days, which is compared to the national average is about 6 days. So it's well over double that. And the average length of the stay before and after being involved with the pathway team was 5 days. That wasn't affected at all. So what can we take away from this, particularly from this what's worth saying with this before and after data that we were looking at? Firstly, was that we excluded the index admission. That wasn't counted before or after. I think there's sometimes a caution in using that methodology that the index admission can front load your data so that subsequent admissions then are lower. And it's also important to point out here, we've had some fantastic studies and there's a lot of published evidence and particularly Pathway itself, who I'm speaking for. When you start a service and you have a controlled group, i.e. no pathway service at all, this method does show fantastic savings and results. And it does produce wonderful financial savings. There's also been a randomized control trial that has shown, although it doesn't reduce length of stay and admissions, it does still produce financial savings. So we're now saying that actually we need to be a little bit cautious with this methodology going forward with established services, because you lose your control group. You have a more complex population who you're working with, you're building relationships with, you're engaging more in services. So we might need to start rethinking this question of how we collect our data. A really exciting part of the work did show, I think as we know from the observational studies as well, that discharge destination is maintained. Important to note that just under 40% we didn't have a discharge destination for, but even so, 60% of was it 60%? Yeah, maintained their housing or improved their housing, and that was looking at those 4 bands, so whether it went up a band or stayed the same, or went down a band. And this also doesn't take into account those that self-discharged, so that potentially could account for those that their housing status worsened. Having such a broad data set like this means there's so much you can do with it, more than we've probably had the time and the capacity to do. But one thing we were able to look at was the mortality data from this set. So 50 patients died out of those 1,009, that's 5%. 30 of those were during the admission, which meant we could actually look at the reasons that they died, their ages, and then I've just shown how we categorise them just for interest. 16% died 30 days of discharge, and then a further 20 within the 120 days. And the average age of death here was 52 years, which is slightly higher than the national average for homeless people. But what you can see is some of these things, some you would expect, but some does go with the thinking that potentially some of these deaths could be avoidable or preventable. So what can we conclude from this quite large piece of work? I've tried to narrow down into the time available. Most inpatient admissions that we saw had a physical health need, and it was probably appropriate for hospital care. This physical illness was commonly associated with mental illness and substance misuse. I think this all is in line with the literature. Most patients that were involved with the Pathway team maintained or improved their housing status on discharge, and I really think that point is so important. It's something we should really focus on from the teams and the work that they do. Unplanned secondary care usage, so through A&E, was not consistently reduced following interventions, but we did see a slight reduction in A&E attendances and a statistically significant increase in planned attendance, which again is really key, showing that potentially we're getting alongside people, encouraging them to come to their planned appointments and their planned procedures, which again we heard a bit about in case examples yesterday. A lot of everything we saw was inconsistent with the literature, which is always reassuring when you're looking at a large data set. So what can we take away from this? And this is what I'm excited to open up for discussion, and a bit nervous to open up for discussion. So unplanned hospital admissions, these really mark a threshold in deteriorating health. It's a really significant life event for anyone to attend to hospital and be admitted. These patients tend to be a lot more complex. They require longer stays, longer admissions, and this also marks a downward trajectory from that point on, that they will then most likely need more interventions and more hospital stay. And hospital care is expensive, and a complete side point is the way you collect this data. If somebody dies, it looks quite good on your before and after data because they're not coming to A&E anymore, they're not being admitted anymore. And to me, that is just balmy, that is a good thing, that these people aren't costing services. It might actually not be because of the intervention that you've put in place, but more that they're not around anymore. Similarly, with this data set, you don't know if they've just gone off to another hospital area. So there's a lot for thought and discussion. So we really need to be cautious in this before and after idea when you don't have a solid control group. And that is very controversial in an area where we're constantly needing to show change, and we're needing to show that we're saving money and that we need to make comparisons. Actually, why are we still seeking in-year savings? This really should be replaced with increasing resources into specialist inclusion health services and trying to show that the wider outcomes we can achieve, these maintained or improved housing status, the discharge support that we put in place, the getting people engaged with community, surely that, and the personal stories that we experience, surely that should be enough. This piece of work did really show a need for a common data set. I know we hear it everywhere, but even within Pathway itself, each team individually collects different things. It's very varied. Some teams don't have any data, some teams did. So this was one way of trying to do a snapshot of all that the teams are doing in a methodological way. I might have put an extra "all" in there, but it really did show where we can go forward, and it's really exciting with the changes that Pathway are talking about, that we might be able to build on this piece of work and see what we can do to try and go forward and secure the funding and keep providing the services that are so needed throughout the country and beyond, really. So I think that's it. So there's my email there. I'm very happy for you to email, but I'm going to cautiously open up, or hand back to Tim, I think.
Oh, that's great, wasn't it? Yeah, thank you.